Today's discussion is about pediatric cardiovascular system examination. Examination of the cardiovascular system include checking for peripheral signs of cardiovascular system problem, measuring blood pressure, palpating for arteries, measuring jugular venous pressure, examining the pericardium, including inspection, palpation, and auscultation. The peripheral signs of heart disease include clubbing, cyanosis, anemia, and edema. So check for clubbing, check for cyanosis at inner surface of the lower lips or lower surface of the tongue or fingers. Check for sign of anemia, check for pallor on conjunctiva, the tongue, palm, or even sole. Check for edema, pedal, pretibial, and sacral. Next is measuring blood pressure. But before measuring blood pressure, we should have to select the correct BP curve. We say the blood pressure is correct or appropriate if the width of the inflatable bladder of the calf is around 40% of the upper arm circumference and the length of the inflatable bladder is around 80% of the upper arm circumference. Calves that are too short or too narrow may give false high reading, whereas calves that are too long or too wide give false low reading. Systolic pressure lower in the legs than in the arms are also abnormal. Normally, systolic pressure is 10 to 20 mm of mercury, higher in legs than in the arms. After measuring blood pressure, check for arteries. Pulse rate should be counted. Count pulse rate for 50 seconds and multiply it by 4 if the rate is regular, and count full minutes if it is irregular. If the rhythm is regular, you count it for 50 seconds and multiply it by 4. If it is irregular, you count it for full minutes. Irregular rhythm can be regularly irregular, as in the case of atrial fibrillation, or it can be irregularly irregular, as in ectopic beats, for example, atrial or ventricular premature contraction. Check also for volume of the pulse. Check whether it is weak, full, or not palpable. And check for radiofemoral delay. If there is radiofemoral delay, we should have to strongly consider coarctation of aorta. We check peripheral arteries at brachial, popliteal, ulnar, radial, posterior tibial, and the dorsalis pedis, and also carotid artery. The next is venous system, especially measuring jugular venous pressure. Systemic venous pressure is much lower than arterial pressure. Venous pressure falls when left ventricular output or blood volume is significantly reduced, whereas venous pressure rises when the right heart fails or when increased pressure in the pericardial sac impedes the return of blood to the right atrium. That means pericardial effusion. The venous pressure changes are reflected in the height of the venous column of blood in the internal jugular vein, termed as jugular venous pressure or JVP. First of all, we should have to differentiate jugular vein from carotid artery. Jugular vein, the pulsation is not palpable, whereas carotid artery pulsation is palpable because it's an artery. Pulsation of jugular vein is obliterated by pressure above the clavicle, and the pulsation of carotid artery is not obliterated by pressure above the clavicle. Level of pulse wave decreased on inspiration if it is jugular vein, and increased on expiration, whereas breathing or respiration doesn't affect carotid artery. Sternal angle is the reference point for JVP. The sternal angle or angle of release is the top of the JVP, usually between 0 to 4 cm. Level of sternal angle is about 5 cm above the level of mid-right atrium in any position. JVP measured at more than 5 cm above the sternal angle or more than 4 cm above the right atrium is considered elevated or abnormal. The venous component, the next is hepatojugular reflex or abdominojugular reflex. The palm of the examiner's hand is placed over the abdomen and the firm pressure is applied for 10 seconds or more. A positive abdominojugular test or hepatojugular test is best defined as an increase in JVP during 10 seconds of firm mid-abdominal compression, followed by rapid drop in pressure of 4 cm on release of the compression. The most common cause of positive test is right side heart failure secondary to elevated left heart filling pressure. The other is examination of the precordium. For most of the cardiac examination, the patient should be supine with the upper body raised by elevating the head of the bed or table to about 30 degrees Celsius. Two other positions are also used, including turning to the left side and leaning forward. The examiner should stand at the patient's right side always when examining the precordium. Anatomic location of sounds in terms of interspace and their distance from the mid-sternal or mid-clavicular line should be measured or seen. Identify the timing of impulse or sounds in relation to the cardiac cycle. Use palpation of either the carotid pulse or the apical pulse to guide the timing of your observation. Both occur in early systole, so if you see any problem during carotid pulse or apical pulse, it is systole. The first part of precordial examination is inspection. Inspect for any deformity or precordial bulge. Check for scars and the activity of the precordium, whether it is active, hyperactive, or quiet. If there is pulsation at more than two or more sites, we call it hyperactive precordium. We say it quiet if it is totally silent, and in this case, the patient is most of the time dead. Apical impulse is the most lateral and is the most downward impulse. Apical impulse is, in most patients, apical impulse is at a point of maximal impulse. So in most patients, apical impulses are the same place as that of point of maximal impulse. But always apical impulse is the most lateral and the most downward impulse, whereas point of maximal impulse is the place where the pulse is maximum. So there are a case at which a point of maximum impulse is different from apical impulse. This should be expressed in terms of interspace and the distance from mid-sternum. The second is palpation. Palpate for any tenderness over the precordium, point of maximal impulse, heart sound, thrill, and heaves. Thrill are palpable, low-frequency vibration associated with heart murmur, so it is a palpable murmur. Feel like the throat of pouring cat and are always pathological. Check for thrills by pressing the ball of your hand firmly on the chest. And if there is thrill, timing is very important, whether it is systolic or diastolic, because we classify murmurs as systole or diastole, and the thrill is a palpable murmur. Timing is important by simultaneously palpating the carotid pulse or point of maximal impulse. The site can be apical, left lower sternal border, or base of the heart. So thrill is seen at, it is checked at apical, left lower sternal border, and the base of the heart. Apical thrills can be more easily felt with the patient rolled over to the left side. So ask the patient to roll to the left side to check for apical thrills, the left lateral position. The next is heaves. Heaves can be parasternal or apical. Closely observe the movement of your fingers or thumbs while putting your hand on the left parasternal or apical heart. Heaves tell us enlargement of the ventricles. Parasternal lift or heave tells us right ventricular enlargement, whereas apical heaves tells us left ventricular enlargement. A left parasternal lift is frequently present in patients with severe mitral regurgitation, and is due to anterior displacement of the right ventricle by enlarged expanding left atrium. The next is auscultation. Auscultate for normal heart sound, extra sound, murmur, and precordial friction rub. When you auscultate, you should have to address those four things. need to recognize the normal to detect the abnormal. The room should be quiet when auscultate the precordium. Auscultate at each valvular area at the base of the heart, at the apex and the lower sternal border. First of all, you should have to know our stethoscope before starting auscultation. Stethoscope have two parts, the diaphragm and the bell. The diaphragm is better for picking up the relatively high-pitched sounds of S1 and S2 and the murmurs of aortic and mitral regurgitation and also precordial friction rub. Listen thoroughly through the precordium with the diaphragm, pressing it firmly against the chest. The bell is more sensitive to the low-pitched sounds of S3 and S4 and the murmur of mitral stenosis. So apply the bell lightly. Use the bell at the apex, then move medially along the lower sternal border to check for S3 and S4 and also murmur of mitral stenosis. The timing of earth sound or murmur can be determined accurately from its relation to other observable events in the cardiac cycle, the carotid arterial pulse or the apical pulse. S1 comes with apical pulse or upstroke of carotid pulse. The first and the second earth sounds are produced primarily by the closure of AV and the semilunar valve and the events that command these closures. Extra earth sounds are S4 and the S3 and also gallop. S4 is a pre-systolic sound and nearly always pathologic. This is due to elevated left ventricular end-diastolic pressure causing vibration in the stiff ventricular myocardium as it feels. It is slow-pitched and always checked by the bell of the stethoscope at apex. Cause of S4 include CHF, hypertrophic cardiomyopathy, severe systemic hypertension, pulmonary hypertension, myocarditis, and the like. S3 gallop is usually physiologic in children. This is a low-pitched sound, occurs with rapid filling of ventricles in early diastole. Due to sudden intrinsic limitation of longitudinal expansion of ventricular wall, this is a low-pitched bell heard by bell of the stethoscope at the apex. This is a low-pitched sound which occurs with rapid filling of the ventricles in early diastole. In this case, there is no elevated left ventricular diastolic pressure. It's most of the time physiologic. So S3 is called gallop. If you detect heart murmur, you have to describe its timing, shape, location of maximal intensity, radiation, intensity, pitch, and the quality. Timing can be systolic or diastolic. Systolic murmur is a murmur that falls between S1 and S2, while diastolic murmur falls between S2 and S1. Palpating the carotid pulse as you listen can help you with timing, because carotid pulsation is during S1 or during systole. If it occurs concomitantly with it, it is systole. Murmurs that coincide with the carotid upstroke are systolic. Systolic murmurs are usually mid-systole or pan-systole. Aortic stenosis, pulmonary stenosis are mid-systole. Mitral regurgitation, tricuspid regurgitation are pan-systole or holosystolic, and the mitral valve prolapse is late systolic. Diastolic murmur may be early diastolic, mid-diastolic, or late diastolic. Early diastolic murmur, for example, occurs in the case of atrial regurgitation and pulmonary regurgitation, and the mid-diastolic murmur is in the case of mitral stenosis. Occasionally, a murmur can start in systole and continues without pause through S2 and 2, but not necessarily throughout diastole. Continuous murmur. Continuous murmur is, for example, it occurs in the case of PDA or patent ductus arteriosus. Shape of the murmur can be crescendo, decrescendo, crescendo, decrescendo, or Pluto murmur. Crescendo murmur grows louder, as in the case of mitral stenosis, and the decrescendo murmur grows softer, as in the case of aortic regurgitation. Location of maximal intensity is determined by the site where the murmur originates. It describes where you hear it best in terms of interspace and its relation to the sternum, the apex or the mid-sternal and the mid-clavicular line. For example, a murmur best heard in the second right interspace usually originates at or near the aortic valve, and the murmur of mitral origin usually best heard at apex. Radiation is transmission from the point of maximal intensity. This reflects not only the site of origin, but also the intensity of the murmur and the direction of the blood flow. Explore the area around the murmur and determine where else you can hear it. A loud murmur of aortic stenosis often radiates into the neck, that means in the direction of the arterial flow, and the murmur of mitral regurgitation radiates to the axilla. After explaining the point at which the maximum intensity is heard and the direction of radiation, you should have to grade a murmur. Grading of murmur is into 6. Grade 1 is very faint. Grade 2 is quiet, but heard immediately after placing the stethoscope. Grade 3 is moderately loud. Grade 4 is loud with palpable trill. Grade 5 is very loud with trill, may be heard when the stethoscope is partially off the chest. And grade 6 is very loud with trill and heard with stethoscope entirely off the chest. After that, quality of the murmur is also important, describing the quality of murmur as blowing, harsh, rumbling, and musical. Next, check for precordial friction rub. The adventitious sound may have pre-systolic, systolic, and early diastolic scratchy, scramping component. This might be confused with a murmur or extracardiac sound when heard only in systole. This is best appreciated with the patient upright and leaning forward, and they might be accentuated during expiration. So, to check for precordial friction rub, ask a patient to sit and lean forward and to expire. When we came to summary of cardiovascular system examination, cardiovascular system includes examination of arterial system, the blood pressure, JVP, the precordium, and some peripheral signs of heart disease. Always examination should be in a quiet room. Observe for craving, cyanosis, and the signs of anemia, and assess the BP, pulse, fortis rate, rhythm, and the volume at radial artery. Check for all accessible peripheral arteries, whether they are symmetrically palpable or not, and check for GVP and measure it, whether it is raised or not. Precordial examination. On inspection, check for precordial bulge, any scar, apical impulse, and the activity of the precordial. And on palpation, check for heart sound, point of maximal impulse, its location, diameter, amplitude, and duration, trill, site, and the timing, and the apical and the parasternal view. Auscultation, normal heart sounds should be checked, S1, S2, and check for S3 and S4 gallops, and also check for precordial friction rub. After you examine the precordium, if you hear murmur, timing, shape, location, radiation intensity, and the quality should be described. Thank you for listening and also subscribing to this channel. Have a nice time.